Okay, next I would like to invite Dr. Ankita Singh. Is Dr. Sabarinath A present here? Okay, you'll be the next speaker. Please be ready. Huh?
This side? It's not starting. Good morning, everyone. I'll be presenting a case of herpes zoster optic neuritis. Herpes zoster ophthalmicus, it is a viral infection of the varicella viruses caused by the reactivation and affecting the trigeminal nerve. The appearance of the vesicular rashes, normally they precede the eye manifestations, and the eye lesions are seen in almost 17% of the cases. And the ocular manifestation commonly seen are keratouveitis. They could be secondary glaucoma, retinal necrosis, vasculitis, or optic neuritis. Optic neuritis is one of the rare complications of herpes zoster, and as per the reports, it is seen in 0.4% of the cases. So here's this serving soldier, 33 years old. He was an immunocompetent patient with no known comorbidities. He presented with a sudden onset visual loss in his right eye since 10 days, which was not associated with a pain, redness, discharge, flashes or floaters. There was no history of any trauma. There was no history of any surgery or any complications in the, and the similar complaints in the family. And there was no such episodes in the past. 2 weeks prior to the presentation, patient had developed the pain and the tingling sensation over the right scalp, forehead and eyelid, and it was followed by the vesicular eruptions over the same area. Patient was diagnosed as a case of the herpes zoster and was started on oral acyclovir 800 milligrams 5 times a day for 10 days. On the 7th day of the medication itself, the patient developed sudden onset of the vision in his right eye. On evaluation, the patient had uncorrected visual acuity of the 636, which which accepted no further corrections. And the left eye was normal. The IOP was also normal. The RAPD grade 2 was seen in the right eye. The ocular movements were full and free in all the gazes. And it was orthophoria on the cover test. NTA segments were essentially normal in both the eyes. This was the clinical appearance at the initial presentations, where the hyperpigmented macules and patches were seen over the right ophthalmic branch of the trigeminal region, and subsequently followed up to 2 weeks of initial presentation. Color vision was reduced perception in the right eye, and the fundus evaluation showed a healthy disc in both the eyes. On MRI, brain in orbit with contrast, there was a thickened right orbital nerve with patchy heterogeneous hyperintensity signals seen in the right optic nerve. OCT, macula, and RNFL were within normal limits. The visual field 30-2 and the neurological fields, they showed inferotemporal field defects. VEP showed anterior visual pathway defect with increased P100 latency on the right side. The other investigations, including the blood sugar, CBC, SR, other inflammatory markers and serological tests and Montooks were negative. On the basis of the history, clinical examinations, and the investigations, a diagnosis of atypical optic neuritis right eye was made, and the patient was started on oral prednisolone 1 milligram per kg body weight along with IV acyclovir 500 milligrams 3 times a day for 15 days. And after the completion of the treatment, the vision improved in the right eye to 6/9. However, the RAPD still persisted. Color vision returned to the normal. Fundus evaluation, this was taken after the 2 months of the treatment. They showed pallor in the mild temporal pallor in the right eye. Visual field evaluation, there was a persistent inferotemporal defect in the right eye. The limitation of this case was CSF analysis could not be done to rule out the infection, as the patient was not very willing. Apart from that, there was no other signs and symptoms to support any other diagnosis. Herpes zoster infection is a result of reactivation of the varicella virus, and optic neuritis is a very rare complication occurring in only 0.4%. The mechanism of optic neuritis is rarely known. However, the proposed mechanisms have been, it's a direct invasion of the virus to the optic nerves to the cavernous sinus. It could be the local extension causing the damage to the optic nerve, or the ischemia of posterior ciliary vessels, which had caused the inflammation of the nerves. The diagnosis poses significant challenges, but the close temporal association of the optic neuropathy after the onset of cutaneous zoster virus gives a clue. Other brain MRI and inflammatory markers are a significant test to rule out the diagnosis. Treatment, the mainstay remains the steroids along with under the cover of IV acyclovir. However, the randomized control trial and prospective studies are still not done. And the fact that the ocular symptoms are caused both by the active replication of the virus itself with the concurrent inflammation supports the treatment regimen here. These are the previous studies which have supported the same treatment regimen. To conclude, RAPD prompts the urgent investigation and management for the better visual recovery under the condition when herpes zoster is already present. And in a patient with optic neuritis, here we recommend the use of corticosteroids with acyclovir for the better visual recovery. These are my references. Thank you.
So for how long was the steroids given?
Ma'am, for 15 days. 15 days, ma'am, oral steroids were given.
Just same dose without
Yes, ma'am,
tapering?
same dose, ma'am.
So many case reports are there about this. So how is your case report different from those case reports?
Sorry, ma'am.
Many case reports are already there in literature of
Yes,
this
ma'am.
complication. So
Yes.
how is your case report different?
Ma'am, actually, this was a serving soldier who had no other comorbidity, and he was deployed in a very high altitude stressful area. So probably this might be one of the stressor for the reduced immunity in his case. So that is why this patient came in the light, and he had no other symptomatology at the time of the presentation, ma'am.
So you can add this to your paper, no?
Yes, ma'am, we have added this actually.
Okay.
Was VEP, visual evoked potentials, done?
Yes, sir.
Okay.
That showed P100 latency, sir.
Right, okay.
Patient's visual field is typical of optic neuritis, do you think so?
No, ma'am, it was not typical of optic neuritis. It was more towards glaucomatous, but however, the other field, the other eye was normal. There wasn't any this thing, and precisely the Anderson criteria were not fulfilled in this case, ma'am. So, and along with the MRI findings and VEP, we made a diagnosis more towards a neurological.
What do you mean by Anderson criteria is not fulfilled here?
Ma'am, in this case, normally in the two consecutive Anderson criteria, 30-dash field, glaucomatous hemifields are abnormal, then the non-etched points.
That is the earliest. It's a very, advanced visual field defect. In the
Yes, ma'am.
earliest case in Anderson, what you are describing is the earliest stage of Anderson criteria.
Ma'am, but
And the CD ratio is definitely in the both eyes, the asymmetry is there.
yes, ma'am.